We then go through lines of therapy, and we're going to talk a little bit about subsequent lines of therapy in a minute. But I kind of want to stop a little bit and talk about, okay, so patients have done their ox-based, their Erie-based, it's 1 to 2 years later. How's that patient different now?
Tired.
Tired.
Bald.
Bald.
I would hope their hair would grow back at some point.
Well, if you've
I
just
was
used
hoping that too.
yeah.
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 So, what are they like?
Well, this again speaks to biology, because there are people that have made it out that far because they have more indolent disease. They've had good responses. Maybe they've been able to have a prolonged period of maintenance therapy. Maybe they could even stop maintenance therapy temporarily. So I think those people are different than the ones who, it seems like you're going to the next line of therapy so quickly. Those are definitely, their performance status is declining.
Yeah.
You know what's interesting, though, is that after those first 2 rounds of therapy, this is where the bottom falls out, right? So they've been sort of trucking along, usually a good response in the first line, pretty decent in the second line. And I find patients, they're not, I don't know how much you discuss it with them, but they're not quite prepared for the fact that things are about to take a turn for the worse pretty fast.
Yeah. And I'm not sure we do a very good job of this,
Yeah.
because we're, cheering them along and trying to be optimistic about next thoughts and clinical trials that we've got and all of that stuff. And I'm not sure we really do a good, I know I don't do as good a job in that point of describing that transition.
Yeah.
Do you all incorporate that into your, I know you're really, you're
really try
focused
to.
on, you tweet with your patients, I know.
I do. But no, I really do think
I'm
it's
on her
important.
feed, so I happen to know.
I think it's important that people understand that when you meet them, if they're being treated for palliative therapy, it's treating it like a chronic illness. And at some point, things may change. And we have to change with how their biology changes. And sometimes it's not always going to be favorable, but it's just a matter of really communicating to them along the way,
Well,
along
and
the
they've
journey.
been on, websites and gone to 5K races and all of that, and seen those 4, 5, 6 year survivors, and they want to be that person, and most of them aren't going to be that, and you don't want to beat them up with that, but you got to sort of coach them through.
Agree. I mean, I think at that point, really from the beginning, I have the discussion that, at that point we're trying to control their tumor as best we can, control their symptoms and make them live longer, and whatever therapies we have available. Mike, to your point about lines of therapy, patients like knowing there's more things ahead, which is one of the reasons I do VEGF therapies in the first and second line, because you mentioned, that they're tired, right? I get tremendous clinical benefit from EGFR single agent as a third line. And
it's kind of a rest too.
Yeah, I mean, their liver function could be abnormal, doesn't matter. They can have cytopenias, doesn't matter. I mean, and so it's actually a nice rest, exactly like you said, a little break before you get to more rigorous therapies.
Should I have them go see palliative care right now?
I thought that was interesting you brought up. The term palliative is one that is...
We call it supportive care.
Supportive care.
Symptoms management. Yeah.
Sadly, we still call it palliative care, and that conversation doesn't go very far.
Well, it's right, because
unfortunately.
it's such a buzz for them,
Yes,
right?
yeah.
But is this the right time, maybe?
Absolutely. They're in our clinic. We work very closely with them, and I think as people get used to the idea that symptom control is as important as the longer survival and the responses that still people want to try to get, that they have this availability of specialists that can focus on that.
And coping mechanisms, ability to help their family, sleep disorders, just keeping the entire patient healthy outside of what we do with chemotherapy.
That sort of don't forget to live message is important here too.
Completely.
I think, is that,
definitely.
You're still slogging, but your reason you're doing it is to keep going. I wonder if guidelines would be, we get a lot of pressure as oncologists from our ICU teams and all of that we don't do a good enough job of communicating this, because we're kind of on the cheerleading side, and they're the Debbie Downer side, if you will. And, maybe it's we draw, this is when the recommended palliative care referral is, but would make sense, I think, even if they're asymptomatic.
An emerging area that I think will make this discussion easier is the whole concept of patient-reported outcomes, and allowing patients to have some type of closer linkage than the way our medical records work now, to be able to report some of those symptoms and have them acted on more rapidly. There actually was a recent presentation at the previous ASCO and now just recently published on longer survival for people that engage in patient-reported outcome type interactions.
Fabulous data, and so everybody, we should give them their Metaport and a Fitbit.